Okay, welcome everyone to round today. It's a great turnout, and I know there's 25 people online, so it's really amazing. So welcome, Dr. Nicole Mittmann. Nicole is the Chief Research Officer. I guess only one, yeah, that's more at Cancer Care Ontario. She also has a faculty position at the University of Toronto in the Department of Pharmacology and Toxicology, and is an associate scientist at Sunnybrook Health Sciences. And as CCO, she's building the first strategy framework for research as an organization. So she's done quite a bit of work in terms of economic evaluation, outcomes research, and drug and patient safety in her career. And now conducts studies where she looks at determining the burden of cancer from a Canadian health system perspective, and also developing economic guidelines for oncology products. Actually, I should ask you about this piece. That's really, really interesting to me too. She also does a lot of work measuring health preferences, and I know that many students have cited your paper from, I don't know how
1999, the last century.
Yes, yeah, exactly. So I keep recommending it, but I don't know when the new one is out.
A new one coming. There should be a new one coming.
There should be a new one coming, right? Okay, so that's not what it is today about. But and Nicole is also co-chair of the Committee on Economic Analysis at the Canadian Cancer Trials Group. So welcome, Nick. Welcome, Nicole. I think the invitation goes back to winter. Cold winter day had where I think it was freezing. It was really winter, and we attended a meeting, and she talked about data and data access at Cancer Care Ontario, and I thought I never heard about it actually. I didn't, or not heard about it at all, but I didn't know everything is something really nice for this club here. Now it's nice and warm outside. Anyway, so welcome, Nicole. So before we get started, and it's a lot of people today, so super quickly say who you are and kind of where your affiliation. So I'm Beata Sander. I'm a scientist here at THETA. I'm also associate professor at IHPME.
I'm a PhD student at THETA. PhD student at THETA.
Actually, Joanna first. Oh, we forgot the other one.
Joanna Bielewski. I'm a research librarian here at THETA.
Well, a PhD student at UHN.
I'm Adam, a PhD student at UHN.
Shabir Bioscientist at UHN U of T.
Jeanette, I'm a research analyst at Princeton Middle. I'm Chloe, I'm an MSc student at St. Michael's. I'm Lauren, a PhD student at THETA.
I'm Austin, PhD student at THETA.
I'm Keegan, I'm a consultant at Ameris Consultants.
I'm Ruhi, research coordinator at Ivey.
I'm Interventional Radiology Fellow at UHN.
Brooke, research associate with UCS Research Office.
She has all the real dirt on the data.
Steven, PhD student at THETA.
I'm Lauren, market access at Roche. I'm National PhD at UC.
I'm a Lucy, biostatistician.
I'm with the Martin Scientific Associate. I'm Fama, PhD student at St. Mike's.
I'm Nicholas Miskagas. I'm a biostatistician at UHN and assistant professor at IHPME.
I'm Estella Rosie, Estella I'm Suzanne, a research associate at THETA.
I'm Eva, research associate at THETA.
I'm Sneva Eman, I'm an assistant professor at IHPME and clinical epidemiologist.
Did you see Brooke? You two are going to connect. Okay.
Right.
Marie Kron, Director of THETA.
Alex, Health Economist at THETA.
I'm Moretti, I'm research associate at THETA.
I'm Basim, pharmacist at UHN.
I'm Nicole, I'm a research associate in cancer education.
I'm Kirkoni, Research Associate at THETA.
Valerie, Associate Director of THETA and Scientist at UHN.
Alexandra, I'm a postdoc fellow at THETA.
Joseph Long, research associate at THETA.
Troy Francis, Research Associate at THETA.
Thanks so much, everyone.
You're not going to do everybody online too, are you?
Oh, no. Then the hours up, and you haven't had a chance to actually give your talk. So over to you. And the way I know you, I think you probably welcome questions.
Anytime. Yeah,
anytime,
I think we'll
right?
do this rather than just talk throughout, just ask questions throughout. And I have to say, when I walked in here, I liked the picture when I had very dark hair. That was a few years ago. It's gone lighter because this job is making me grayer. So anyway, so thanks very much. And Beata actually asked me to present slides from our Calgary meeting, and we talked at that meeting about data access and issues around sharing data, and certainly between provinces and definitions of data. So I thought I'd put some of that in this talk and then talk a little bit about some of the research activities that are happening at CCO and give you my role is a fairly new role. I've been in that role for about 2 years now. And the goal was to sort of generate a research strategy for the whole organization. So I'm going to call it CCO. Some people know it as Cancer Care Ontario. I'll give you a little bit of background on why we call it CCO now. So I have no conflicts. I think that's probably one of the first times I can actually say that. I used to have a lot of conflicts. So we're just going to talk a little bit about some of the background of CCO, some of the projects that we talk about, and then some of the data. And at the end of it, I have my email address on there and our data request email as well. And if you have questions, please don't hesitate to email me or the data request group at CCO. And so I'd like to say, I usually would like to stay around and talk, but I had a thesis defense at Sunnybrook this afternoon, so I'm going to have to run up. But if you please don't hesitate to email me. So this is sort of, CCO used to be Cancer Care Ontario, sort of government advisor for cancer and kidney. And you'll see that we've evolved beyond the cancer. We are part of the Ontario government, and we're a government agency as part of the Ontario Ministry of Health. But we're governed by the Ontario Cancer Act, but yet we do more things than just cancer, right? So the idea was to figure out a new acronym at some point in our lifetime, but now it's just called the CCO. So we have Cancer Care Ontario and the Ontario Renal Network, for those of you who are in that space, and thinking about prevention, screening, all the way to end-of-life care, right? So there's a whole host of different things that we do. And we have lots of different data sets and databases around that. So just that's one of the reasons we're going to talk about some of the scope of the types of activities that are happening. The other thing is we are, and I meant to bring this slide, but we are a prescribed registry, which means that we're allowed to have registries of personal health information. We're a prescribed entity, right? It means we're allowed to use PHI. We're also a HIC, which is a health information custodian. We're also a charity, right? So we have at least 4 or 5 different designations, and depending on the legislation and how you ask your research question, we may fall under a number of those kind of registrations, which means that we are actually allowed to talk to patients or send correspondence to patients, for example, because of the status that we have. So that I'll talk about that a little bit later when we talk about patient contact studies. So research, and from my perspective, I haven't been around for 75 years at CCO, but this is our actually 75th year coming up at the organization, and really has been, we used to be the Ontario Cancer Treatment and Research Fund, right? And so now we've broadened that sort of perspective. So it just gives you a little bit of information. This is how I always think about CCO. This is not an official slide, but this is how I sort of bucket it. So there's the Cancer Care Ontario stream. There's the Ontario Renal Network stream that we have. We have an access to care, which is all the wait time data that people have, and actually we provide wait time data to Health Quality Ontario, who then provide some of the wait time information and indicators. We have the electronic Canadian Triage Acuity Scale, so we can talk about that too. That's an actually initiative that was the Ministry of Health asked CCO to actually put together the triage in electronic form. So every hospital or every emergency room that triages patients, they were doing triage in 3 different ways. One in their head, and they were giving people scores, triage scores in their head. Some were doing it on paper, some had their own algorithms, and now we're actually put it in an electronic system where there's actually a live linkable data set to actually link in there, and it would have not only some of the symptoms, but patient characteristics and the reason for the visit, and very detailed reason for the visit, which then all adds up to what is their triage score, for example. So that's a new initiative. That's actually in 40 hospitals right now, and by the end of this year, it'll be in all emergency rooms across the province, which is really interesting because when they swipe their health card, we can then start to link into the data set. So people that are doing work on adverse events or that lead to hospitalization, that's actually a potential opportunity to do some research there. Well, we also have, we are sort of the steward for the Ontario Palliative Care Network, and that is a huge group of people that includes LHINs and hospitals and community care access centers we're sort of the steward of that organization as well. And then we've done work in dementia planning and capacity planning, and then we've also done work in mental health capacity planning, right? So they're not they're not even dotted lines, they're just projects that we've been involved in because of the ability to connect to patients and to systems, and through, because we not only have cancer systems, we also have dialysis systems and renal networks, right? So then there's the ability, how do we actually do some of that? So it just gives you a little bit of an idea of the scope of the activity that happens at CCO. So this is the strategy roadmap. So this is one of the things that I've been working on. And so when I first arrived at CCO, one of the things that they were trying, they had research all over the place, all different kinds of things, sometimes related to policy and sometimes not related to policy. So one of the things we started to think about is because we also have, you remember that slide before, not just cancer, we have other kinds of diseases that we look into, is to create a strategy that actually is disease agnostic. That when since we answer to, the I always say we answer to the patient, the taxpayer, and the province. And at the end of the day, if the province is interested in us looking at dementia capacity planning, we will do so. So we had to have something that was nimble enough that didn't actually have a focus on a specific disease, but focus more on kinds of foundational pieces in what we do. So if we look at the first part of the top, which is one of the things that CCO does, is their mission statement is they will improve population health, quality, and value of care. So why aren't we doing research in trying to figure out how to improve population health and value and quality of care? And that's sort of where we started. And then thinking about this constant improvement, this audit and feedback, this learning health system, where we actually put things into the system and then we can evaluate their impact into the system as well. And I think that's sort of where we started. And in order to have sort of a learning health system framework, one of the things, or a couple of things we needed were some foundational core pieces of information. So we needed data or information. And so we'll talk about some of the data sets that we have in the upcoming slide, but not only data from databases, but data from patients, whether it's survey data, qualitative, quantitative data, so we needed that piece. So I think, we have 80 plus data sets at CCO, and so I think we have lots of data. We partners, well, as mentioned already, taxpayer, patient, province, academia, LINs, regional programs, all of dialysis units, emergency rooms, right? So there's lots of different partners that we have to play with. In order to have a robust learning health system, you need to have partnerships. We also have a very big patient and family advisory group. And so that patient and family, I think we're about 200 strong in terms of patients who provide us with their feedback on how the system works. Actually, the work that our group has done has actually gone back to the ministries, actually put their own patient and family advisory group together based on some of the components that we've had as well, because I think our group's been around for about 10 to 15 years. And so there's an opportunity to learn from ideas. And in fact, some of the research calls that we've had from a funding point of view have started it with questions that the patients and family advisors have wanted. Like, how do we change wait times? How do we improve access? These are the kinds of outcomes we're interested in. These are the symptom things that we're interested in. If you think about that sort of, we're looking at things at a population level, that's something that we can address. And so that's partners. We have lots of partners. Governance are things like legal and privacy. Can we share? Ethics, can we do this ethically? Thinking about the privacy piece, I think I should have an honorary degree in legal and privacy now. I should go back to law school and just do that, because I spend a lot of time with our legal and privacy office. How can we share data? How do we transfer data? Who's allowed to have access to data? Conflicts of interest around access, all those kinds of things. So we spend a lot of time with governance. We don't have our own ethics committee at CCO, although public health does, and we're actually trying to figure out a way if we can actually coordinate some of those activities. Because right now, if you're a researcher, whether internal or external, you would go back to your host institution to actually put research ethics through there. But if it's an actual initiated project out of our organization, we should probably have some sort of oversight or at least ability to do that. So we're working on things like governance. Even just governance around, is a breast cancer case in your unit the same as a breast cancer case in the other units, right? And so I remember one project we were working on with them, looking at a palliative care cohort, and there were 5 different definitions, slightly all different than one another. And so, should we streamline them, create dictionaries to make sure that we're actually starting to talk about the same things? So that's governance. Culture. So culture trumps strategy. You can have the best strategy in the world. If the culture isn't ready to move or think about this, you're not going anywhere, right? And I think over time we've started to convince people where I'm going to say this in a very crude way, I felt like I was a seagull coming in and pooping on things. They say, well, what about that method? Or what about this method? Or did you think about doing this, right? When people started, what about a control group? And so we started to think a little bit around, could we ask more thoughtful questions rather than just surveys or just indicators with lots of bar graphs, right? So thinking a little bit around trying to change the culture that way. Analysis, we have lots of analysts, right? We have analysts, we have about 200 analysts that work with the different programs at CCO, right? And it's all very PhD level sort of skill sets of, you know, how do we actually look at the data? How can we start to do some inferences and some outcome data as well? And then outcomes, you know, we have everything from whether you needed a transplant or whether, you know, there's death data as well, but, you know, we're starting to think about the intermediate outcomes, recurrence for cancer, progression for cancer, how do we do that? And even the patient-reported outcomes, particularly, I don't know if any of you use the Edmonton Symptom Assessment Scale or even aware of it. I think it's in 78 different locations, mostly at regional cancer centers. There's a kiosk that patients go through and they can complete their symptom data at each visit. And if you think about, so the symptom data is the Edmonton Symptom Assessment Scale. There are 9 questions, everything from dehydration to fatigue, pain, and so they complete this, and again, after swiping their health card, which then goes into the database. You should also know that in the past year, probably the past year, the ESAS data in the data sharing agreement with ISIS has actually moved over to ISIS as well. So we do continually update, and so that information is available. So there are 6.8 million entries of patient-reported outcomes, so symptom data. Longitudinal, cross-sectional, there's lots of opportunity to start to look at that as well. So we have lots of different kinds of outcomes. We also have patient experience measures, satisfaction, how are you doing, are you happy with the system, all those kinds of things. So psychological and social sort of burdens, and we're starting to think about more financial toxicity, imagine that, and starting to think a little bit around how can we measure that, and can we do that in a systematic manner instead of surveys or small populations, because we would have access to all the patients in the system in order to do that. So that's the foundational pieces. All those are components of having a learning health system, and then we have to think about, well, what do we want to do in our research goals? Well, since I sit at CCO, we want to increase our CCO contribution. That makes sense, right? But then the other one is expand the kinds of research we do. We still have a very strong group in prevention, our epidemiologists and screening, but we didn't have a core group of people sort of who did health technology assessment, or maybe there were some, but not a whole bunch, or were there other people who do qualitative studies. And so expanding into the kinds of research we do from a methods point of view and also from an area point of view. And then we want to start to implement evidence more actively. So how do we do that? So implementation science, and how do you actually, you know, we have one of our corporate standard phrases is we rapidly transform evidence into practice. I don't know whose definition of rapid we're using, right? But that's the goal, right? And try to think a little bit around how do we do that, and how do we get evidence into practice? Because we have the levers, we often have funding levers, or we're able to contact individuals, or we're able to just sort of put programs together. We actually have an opportunity to do that, right? So now we have evidence, and how do we actually get it into the system? And that's sort of our role. So that's the research sort of goals. In terms of themes, they're sort of standard themes, right? So we have, like I mentioned, population health. We had a big group, and we still have a group in prevention and screening, but healthcare delivery is important. So this is where we have our patient-focused outcome. If they listen to the administrative person, a patient-first initiative, right? So we need to include patients in either decision-making or consider some of the outcomes and metrics that they have, and then collect some of the data. As mentioned, there's the patient-reported outcomes. And then how do we integrate healthcare? And I just came from a meeting earlier on today about an integrate study where it's actually trying to integrate a whole host of people who are palliative specialists from different groups, and how to streamline people through the system. As folks here would probably think, you know, let's figure out the value of things. So or the cost effectiveness of stuff or efficiency. We're actually looking a lot at choosing wisely, and I think I have a slide up there about choosing wisely, so getting rid of inappropriate and redundant care. So from a system level, it makes sense, right? So thinking about if you actually can organize the system in such a way that you're being more efficient, you might be able to use resources somewhere else, right? And then best evidence, this is trying to get that evidence out. How do we disseminate it? We spend a lot of time, and CCO is very good at guidelines. We have our program in evidence-based care. We had a lot of our clinical guidelines, at least in the cancer space, are adopted internationally. So how do we do that? But then I follow up and say, and does anyone follow the guidelines, actually publish them? Does anyone actually look at them? Do you actually, has there been a change as a result of those guidelines? So we spend a lot of time talking about those things, and then how do we implement things actively? And are there frameworks for implementation? What kind of evidence do you need? We know that there's a certain level of evidence you need for health technology assessment to say something is, cost effective or not, but then what's beyond that? So looking at groups, working with groups like CADIS and other groups around how to then implement it, because we're really, because of how we sit in the organization, we have the capacity, like we have the system change piece, right? So if you're going to implement a new technology that requires a change in personnel, or a different type of personnel, or more chair time, or whatever you're thinking, or more transplant time, there's capacity building issues that are required in the province. Do you think that this will change the, let's say, the number of transplants? Well, how many can we even do that kind of idea? So we spend a lot of time talking about that. So that's sort of the strategy itself. It gives you a little bit of an idea of where we're going. And so the other thing that I wanted to highlight as part of this, so what everybody needs metrics or indicators. That's one thing I learned very quickly. And so you can do the standard things like how many publications and how many presentations and how many students you have, right? But then I think because we're at a system level, did this work inform decision making? Like did it inform, did it change, did it amend a policy, did it make a policy? So all those kinds of things are important to actually look at. And then did it have a health impact? Like if you actually put something into the system like a program, did it change the number of emerge visits, for example? And then broad economic and social impacts, right? So this is some of the choosing wisely work in terms of efficiency. So this is how we're starting to look at some of the ways to measure some of the proposals or some of the questions. The other one is sort of the research results. Like this is where we're starting to think, did it have a system change, right? So there's different sort of categories where it's like the use of research supported ideas, or all the way down to instrumental, where they refer to a direct change. And one of the really good ones that I can think of as an example of an instrumental is Anna Curley is one of our scientists in the breast screening program, or is the scientist in our breast screening program, and she did a study looking at film mammography versus digital mammography, and found that you actually picked up more cancers with digital. And once that paper was published and the interim results were seen, they actually changed every machine from film to digital across the province, right? That's like a $20 million investment of just making sure that you're getting better care, right? So those are the kinds of things that was directly used to actually change that. So I'm going to show you a couple of examples. I don't have all of that. I wanted to show you a choosing wisely example. Some of the work that Kelvin Chan is doing on real world effectiveness, trying to think about do we actually get the benefits of the outcomes that you have in clinical trials, and putting on my clinical trial hat through the clinical Canadian Cancer Trial Group. It used to be MCICCTG, which I could say really fast, but the other one I have to think about. I feel like I'm stuttering. But the piece of, we know what the cost effectiveness or efficacy is from a trial. Does that actually, the outcome, does it actually happen in the real world, and with different kinds of people who are not necessarily involved in a clinical trial, right? People with more comorbidity and more drugs and elderly age and different functional statuses involved in the trial. Models of care, we have lots of different kinds of models of care. So can you put an integrated program in place, or can you transition people over from one group to another? So we'll talk about that. And then I already highlighted our patient-reported outcome group. And Lisa Barbera has been a radiation oncologist with Sunnybrook for now. She's moving up to Calgary, but she has been working specifically with that ESAF data, and actually ended up linking a whole bunch of data sets through ISIS, actually, through saying, if you had an ESAF, scale or score, and then looking at pain, and then linking that pain to when did you get opioids and not, right? And thinking from a system level approach, if we can identify people who aren't getting access to opioids, if they are high pain sort of scores, what can we do at a system level, right? Taking it from there to there. So this is just a couple of the Choosing Wisely examples. So this is, if everyone goes on Choosing Wisely Canada, this is if you go under oncology, this is sort of one of the first ones, don't order a test to detect recurrent cancer. So one of the projects that we actually start to look at is who's doing that in the province, right? So if there's not a realistic expectation that there should be any recurrence, then how do we do that? And so we had This is Matt Chung out of Sunnybrook, and Craig Earl and Simran Singh and a couple of other people there who are either at ICE and abroad. But we started to think about, what's the system impact of this? Like, what actually are we doing? So this was just published, excuse me, in, it was published in, I think it was published earlier this year or even later this year, like last year as well. But just thinking about, looking at CT, and there was a lot of CT extra imaging that really wasn't appropriate given that guideline for choosing wisely. So what do we do at a system level? So one of the things that we've done with this has now started a discussion internally about how do we change that? Do we have to, because we have sometimes funding buckets or ability to say, how do we change some of this around? So that gives us a starting point. So we meet with our, there's a value for money team at the organization and say, how do we actually change that into a cost, and what do patients want, and what do physicians want, and there's a whole host of other things that happen as a result of that. The other one is it's also models of care, but it falls under actually choosing wisely initiative too. So this was, don't deliver care in high cost settings if you can deliver it elsewhere just as effectively. And so was a big group out of Cancer Care Ontario that actually put in a model, a project that actually found a whole host of sites and then decided to transition women who were well with breast cancer to their family practice. And then so looking at what were the outcomes, what was the satisfaction level, did anything change with respect to outcome, then what were the resources that were used and what were the costs. So we're just actually this has actually just been submitted for publication. So I'll just show you that. So we were thinking, what we ended up doing was we took that registry or that sort of project that happened in the centers, and we actually moved that data set, right? So sharing data, moved that over to the Institute for Clinical Evaluative Sciences and created a matched cohort. And then started to look at, we matched by propensity score, and we did some hard matching as well. And so we created all women with breast cancer, except some were in the well follow-up program, according to the program that we enrolled them in, and others were in the control group. And so just thinking about annual physician visits, we started to look at, our hypothesis was that if you were transitioned over, then you might have more physician visits, more family practice visits, for example. That actually didn't happen. And we actually had fewer medical oncology visits, which would really set some of the goal of trying to do that and increase the capacity for medical oncology, and also some of the radiation oncology visits as well. So just thinking a little bit around what actually happened. And they didn't go to the emerge more often, which is another thing that we were worried about. Like if you actually transition back to your family practice, that maybe they wouldn't have access to care as they had previously thought, and so would they go to the emerge as well? So that didn't really show much of a difference. And then we started to look at cost because we have the beautiful get cost macro that we've been using. And so just like, what are we actually looking? So these were 8 cases that went through the program of the well follow-up program compared to controls. Was there actually a difference in not only resources but also in cost? So actually that particular group was less expensive than the controls that we found. There's home hemodialysis and policy. So because we're not just cancer, we're Ontario Renal Network. So one of the things that, here's an idea of getting people to actually use home hemodialysis, and given the fact that there's potential clinical similar outcomes, potentially more cost effective, we don't know. And so one of the things that we were starting to look at was, how many people are getting home hemodialysis and were there any barriers to getting that? And so the group actually through the Ontario Renal Network started to think about, well, part of it was around financial toxicity. There were large out-of-pocket costs associated with electricity and with utilities, so water. And so like if you want to transition people over into home hemodialysis, you don't want to actually have them have an undue burden, right? And so one of the things that we talked about, so 70% of individuals reported a drop in their annual household income as a result of starting dialysis, and there was a whole host of work that is just now being put together actually into publications around, how much additional utility costs there would be. So our Ontario Renal Network then spearheaded an initiative to work with the government. Could we actually fund some of these extra costs through the health system rather than, so that's a novel thing because the health system usually doesn't fund non-health system stuff, right? So this is, could they fund utility and could they fund electricity? So, so part of it, some of the work that was done, well, this is is out of order. Sorry, this is supposed to be the mammogram stuff for the well follow-up. But what had happened was, in very short order, after generating the evidence for for some of the utility, for some of the costs, the ministry actually approved that there would be utility grants available to patients who required them, right? And they actually, instead of saying everybody gets a standard fee, they actually adjusted rates depending on which area you live. So it's actually a very nimble process around that. So this goes back to looking at water, electricity usage, municipal water rate, because they're all different apparently, provincial rates, and Hydro One stuff, and then starting to think a little bit about who uses what hemodialysis. So they actually are now funding, so there's a grant you can apply for if you look online, if you actually wanted to have home hemodialysis and provide. So that's the fun part of being at this organization, because you actually see change that way. So you use the evidence to generate some of that change. So this is what you asked me to talk about, so sorry. But all of the stuff that I talked about before was sort of leading up to this. So here are some things that we wanted to have databases. So we hold over, 80 plus data holdings. And some of them are similar to what the Institute for Clinical Evaluative Sciences has, and some of them are our own generated. Remember, I told you that we're a prescribed entity, prescribed registry. We're a HIC. We're allowed to collect some of this. And if you ask me on the spot, I will have to look at my cheat sheet about what all those databases mean. But just gives you a little bit of an idea, like some of them around screening. There's a lot of colonoscopy ones, specific mammogram ones. Obviously, we have a PET group. And so there's lots of little databases, as well as wait time data as well. Right, so those are all available to use for analysis purposes. And then across the healthcare continuum, there are also databases that are like physician detailed information. So the green is what we collect, and the blue is what's collected by other agencies like the ministry or CIHI or others. So symptom management, the patient-reported outcomes, and then the EPREM, which is the electronic patient-reported experience measures that I talked about earlier on. The registries with the Ontario Cancer Registry as well, which has been going since 1964, right? Cancer staging, we have about up to 90% of cancers, 95%, and the top 4 or 5 cancers are staged well, and then over time they're increasing. You can imagine it's an ongoing initiative, right? And we only stage once at index, right, or at diagnosis, and we don't restage. So that's part of the discussion around how do we actually see if people progress or not progress, and that people have algorithms in place, and other groups are putting AI onto it to say when does someone progress and when does someone become metastatic. So there's lots of other fun stuff going on there. So that just gives you a little bit of a snapshot of some of the databases. So we can provide record level data, but we have to still meet our obligations, all right? So if you have a request as an external researcher, you can actually go through our data disclosure committee and make a request, right? So part of it is, it has to be a bona fide study, it has to have research ethics approval, there has to be a discrete question that has to be answered. So part of it is, I'd like to just go fishing. That's not going to fly, right? Even under our legislation, we're not allowed to do it. It has to be for a defined research question. There can be no permanent linkages. So people that already have registries, that want to link into their registries, we have discussions around how long you can keep the data and when you have to destroy the data, all of those kinds of things. Right now, it's no out of province use, but we're spending the meeting that we had in Calgary was to figure out how to do that more efficiently, because we actually all have very similar privacy legislation. Alberta is not going to do anything different than Ontario. It's just the interpretation. And so I think we spend a lot of time talking about that. When people make a request, detailed description of some of the data elements, and actually there's a really iterative process between our data disclosure committee and sometimes Brooke Filsinger, that's why Brooke is here. If you need to talk to Brooke about data, about what data do we have over, and what's the quality of the data, what's the time frame of that data as well. And then security, we could transfer actually, which is different than ICE. We could actually transfer a data set to you, given that you actually meet some of the security requirements.
So, Nicole, do you have data for people who don't have cancer? I mean, so you've got ORN. I mean, most of this, so if you wanted to do comparative studies for like randomly sampled members of the general public, do you hold that? Because it seems like you could do a lot of the ISIS stuff, except that you can't get the general population.
Well, we would have the same. I mean, we have all the. So we would have all the like a high data hospitalization data, but we don't have registries of people with stroke, for example. like I.
No, but you don't get high data for every patient in the province, or do you? You get kind of paper for people in the OCR?
No, we get for everybody. Yeah.
Really?
Yeah. 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 Because we have people coming to us now with questions outside of cancer, right?
Okay.
And so merge visits or you know, cardiac questions kind of thing. So we actually have that too, right? I mean, obviously we've spent much more time since 1964 looking at cancer, right? And so our cancer registry is great, but there are ways to link into the other data sets for other diseases. You know, we have same thing, like different diagnoses, but we haven't created registries for those, right? Like we don't have a stroke registry, for example, or cardiovascular, but you can link into their diseases.
So if that's the case, why would people go to ISIS for any cancer-related issue when it's much easier to work with you?
Well, I don't know if it's easier, but and it's becoming easier, right? So I'm going to tell you that before I was at CCO, I requested data from CCO, and it took me 2 years, and my grant was 3 years, right? So it's not always that easy, but it certainly has become easier, and it depends on what you're looking for. Like if you needed to do costing work, we don't have the get cost macro at CCO, right? We don't have, and we don't. That's the reality. But if you wanted to look at resources or outcomes, or we do have all of that data, and we have like just a different process, and sometimes you can actually play with the data yourself as long as you meet all those rules, right, in terms of privacy and standards. So I'm trying, it's like an advertisement.
Yeah, I guess the next question is just like practically, so you actually transfer the data, so you transfer it to me in my office over here?
It depends on if you have whatever the proper sort of like security and privacy. No, you don't require, so we don't have a portal or somewhere where people can go on and link, like Stats Canada, you have to go somewhere, right? And with ISIS, you have to actually, either a portal you can go on to if you're an external researcher, or you can have an ILS internally do it. You can actually do, so we can do two things. We can actually do the analysis in-house, or you can get the data, keeping in mind that you don't necessarily need, so we go through a very rigorous, like, do you need PHI data? Do you need identifiers? You know, how much data do you need? We spend a lot of time going through that. We actually have a committee of about, what did we say, 10 people. We were just counting them up. 10 people who go through every request to make sure that we're not changing any sort of privacy legislation around there. I see Maurice is rolling his eyes, but it does happen.
Well, no, it's just that we've done a lot of CCO stuff, not in the recent past, but 8-10 years ago, and it was a lot easier to work with CCO than getting stuff from ISIS, and a lot cheaper because
Just still a lot
do
cheaper.
the analysis here as opposed to having to pay enormous sums to ISIS analysts.
So I'm not going to make a comment about it other than if you get the analysis, like you can get the data here and do your own analysis. If you're graduate students here, graduate students can do that here, right? So but it's just whether or not you can actually accept the data. We can share the data and all of those kind of things. But I think we're much better now, and with agreements and streamlining processes to allow that to happen.
So I guess since we're taking all these questions now,
Sure.
Nicole, I may as well ask it. The word on the street now is that the relationship between CCO and ICE is no longer complementary, but has now become competitive. Do you want to comment on that?
No, I can certainly comment on that. There's not that I'm a competitive person at all. No, I think we do very different things, actually. So from a research point of view, if people would like to have access data, they certainly can, right? But they can also go through ICIS. It really sometimes depends on the question. And if you have invested in some of their analyst time, there's a whole host of different things. Sometimes they have better algorithms for some things that we haven't thought of those algorithms yet. So it really, I look at it as a question by question thing. We actually really are interested in the system level piece, right? So not so much, here's the research question about which adverse event does what with clopidogrel, I'm just using an example, but we're actually just like, how does this change the whole system, right? How do you affect it? So I think they're very different objectives, actually.
If I could follow up on that, on a specific level, for elements of the cancer registry, and I know that there's data sharing between ICIS, but there's been significant delays or sort of, I guess, temporary cessation of certain data flowing. And again, the word on the street is because CCO is building its own shop and isn't playing in the same sandbox with ISIS anymore.
No, I think we have a very good, just so you know, we have a very good memorandum of understanding with ISIS. We share, we partner, we talk a lot. We spend a lot of time now sharing algorithms, for example. When the ministry came to us about dementia capacity planning, we wanted to make sure that we were using the right definition, and ISIS had the right definition. And so we shared information on CCPs and codes and all of those things. So it's a very collaborative, it's not competitive at all. And in fact, that's how I look at it. And so, in fact, we attend at least their cancer program meetings. We attend those to see what projects are there. If there are projects that people are doing that we're interested in, we make sure. So my role is often the bridge to say, hey, you thyroid people here internally at CCO, do you know that there's a project going on here, and just try and connect them and make sure that they're outcomes that are useful or manageable, or, you know, that are can streamline some of that. So I think of it much more as a collaborative effort, and we do have very open communication. In fact, what's very interesting is one of our lawyers at CCO is just leaving to go and be the lawyer at ICE, right? And so now we'll have a really nice seamless discussion. We know who to pick up the phone with and all of those kind of things. So I think that's reasonable.
Yeah, just a quick question, but
I'd like to know what street you're on so that I can find out what people are saying. I'll follow you home and say, what street is that?
I'll email.
Okay.
you will not have data that you also capture twice, like OHIP data, right? You will not have to.
Yes, we have. So what we have is a data sharing agreement with ISIS, and so they get our Ontario Cancer Registry data, they get our activity level reporting data, which is the chemo and the radiation data that they get, and they also now get our ESAF data, or the patient reported outcome data, and I think some of the palliative care, the PPS one, which I forget what that is. Thank you. They get that one, and then there's one more where they used to get the physician ECOG, but no physician fills that. So I think we might not send that again. And then from the back end is that we get OTB data, we get OHIP data, and we get, well, NACRS comes from national, right, and so high as well. So we have all of that as well. And so what we've also been doing, just to say about the competitive versus the collaborative, we've had so from a collaborative point of view, we have gone to ISIS to present about the Ontario Cancer Registry. They have come to us to present about ODB and OHIP. And our September, October, we will be doing ALR over there. So we've been having lots of in-house learnings about each of the databases, and now people know who to connect with in terms of definitions and all of those kinds of things. Sorry, Dale. No?
So basically we can request data to analyze here if we do it through you.
You cannot do, not through you directly.
No, I mean,
I don't have access to any PHI. I'll prove it.
I think we cannot analyze here, we have to analyze there. But basically, if we have the same information for this cancer group of patients through CCO, we'll get the data.
Yes.
Not even just cancer.
Sorry?
It's not even just cancer, right?
Yeah, and there's other ones, right? So we're testing it out too, right? So for example, there's a cardiovascular request that came through, and we just want to make sure is it the right data, are they using the right definitions? We go through with them to figure out what we can share, what we can. Is it death data, which is how many years behind, all of those kind of, and that's not just our issue, that's everybody's issue in terms of that. But so we can share that information. Our goal is to liberate the data. That's my question. Yeah.
One related question is, I think depending on where we assess CCO or ISIS data, the one investigator more concerned is the time to assess. Do you have a rough estimate if we go into CCO from the starting request to actually get the data?
In fact, I do, because I was the biggest complainer about why did it take 2 years to get data, that was before I arrived there. And so what happened is there were a lot of people who were requesting data that it really took a long time. So the best way to change that is to make it an indicator that you have to report up to the CCO or the CEO. And so one of the things is now we have, for simple requests, it's 60 business days. And that's 60 time of approval, but you've worked through like making sure you have the right DCP and everything, and so we have to report on that. So is it, for those of you who ever do indicator development, it's red, yellow, or green, right? And so every quarter we report if we've hit that target. For complex requests, what are we at now? I think we negotiate on the deadline. Yeah, but so the difference between a simple and a complex request is something like you know, like multiple data sets, right? Like if you have, it just depends on how many people. We're not structured at all like ISIS is structured, right? So we have different people who are SMEs, which I thought took me a long time to figure out what a SME was, because I thought it was like a Lord of the Rings kind of character. But it's actually a subject matter expert, and so we have lots of subject matter experts by each database, and then you have to make sure you have, so it took me a while. But so those are so the complex ones may take longer depending on how many databases you have and how many things you want to extract.
Yeah, we have two people online asking questions. So the first one, what is the level of information linkage with pediatric pharmacology data? Example, long-term follow-up for secondary malignancies in patients treated with pediatric institutions.
I mean, we don't have a permanent linkage with POGO or Pagonis, right? For the pediatric, but we've been having some conversations about how could you link stuff, but usually on a project-by-project basis. And so I think one of the things, what's interesting is when they transition to adults, then you might be able to find them in the Ontario Cancer Registry. We have done projects with adolescent and young adults, right? So what's the age range? And I think some of the projects, the last transition study was age 15, so if they find it, they're in the Ontario Cancer Registry, but I'm not so sure about the scope of like where they draw the line as well.
So another question from another person. Do you also have a post-cancer diagnosis data, say, example, cancer surgery data?
We have cancer surgery data, yeah. Okay. I mean, that's part of, we actually have to report on wait time data, and we also know when they have surgery. We have a lot of projects that are disease pathway data. So, you know, if you're breast cancer, you have this kind of algorithm that you should follow, right? Whatever, surgery, radiation, then drug. And so we have a lot of pathways that we try and map to concordance of those pathways, right? And then supposedly if you have those pathways, then you have good outcomes, higher quality outcomes and lower quality outcomes. Those are the kinds of things we're starting to look at as well. And it's longitudinal data. So we don't, I'm trying to think about this, the new cancer diagnosis, right? It's only the first time incident cancer, and then if you have a separate cancer diagnosis or a different, like the other kidney, right? You see it again in the Ontario Cancer Registry. But we have a woman, Mary Jane King, is the guru of everything Ontario Cancer Registry. So often when people come in and ask specifically about diagnosis, we just send them off to Mary Jane King. The other thing is with pathology reports, right? So those that isn't collected there, so starting to pull the pathology reports. And we've done lots of projects with the Institute for Clinical Evaluative Sciences where we've transferred pathology reports back and forth, and some poor fellow has to sit in the basement in the dark and review thousands of pathology reports. So that's what happens, unfortunately. Yeah, so just this is like the process, right? We have a pre-intake group. We look at the application package. The application package is online, and I have a link to it at the end of my slide. We review it. We have a data disclosure working group. We have a data disclosure steering committee, and there's lots of committees that we go through. We make sure we refine the data set and are allowed to release it, and then there's a data disclosure and invoice. And there's lots of different sort of governance around it, who can be, and our legal and privacy group chairs this meeting to make sure. I just wanted to show you who requested data over the last little while. So some CCO scientists, hospital researchers, and other, right? So research facility could be anything like universities or whatever. And so we're starting to get requests outside of Toronto, Waterloo, all of those kind of things as people sort of go through these. And, you know, what are people questioning on? We're starting to get wait time data, more questions outside of the cancer space. In fact, one of the things for the renal, the Ontario Renal Network, they're a partner with the DOPS, which stands for, it's Dialysis Observational PPCS, whatever. And so this is an international collaborative of which we collect data as well. And so people are starting to request the DOPS data now to see what's going on in terms of use and utilization and psychological and social burden as well. Yeah, so I just thought, like, somebody asked me, you know, what's the long term, like, you can start to do follow-up, longitudinal analysis as well, because we would have access to some of the drug stuff. For those of you who looked at the drug stuff, right, you know, the new drug funding program, some ODP, but ALR is actually the data that should be the umbrella for both, for all cancer drugs. And so it's either systemic ones in hospital IVs, and then it should be actually capture all the NDFP ones, and it should actually capture any of the oral medications as well. It's getting there. So sometimes it's the quality of the data too and what year you're looking at. So that's important. So that's why that pre-intake is really important. All right, that's lovely. Let's keep going. So I think I have 1 minute left. So all I wanted to show you here is that you could have an external cohort. So for example, the Canadian Partnership for Tomorrow project has an external cohort that they were looking at in prostate cancer, and I think prostate and breast. I'm looking at breast because she knows everything. And prostate and breast, and then they had their identifiers, they transferred them over to us. Then we took their identifiers, linked it to data, and transferred it back to them, right? So if you have an existing registry, and those are lots of the projects that we're working on, or you can start at our organization and then get an external.
Do you have similar policies to ISIS then around parat level sort of screening for privacy and small cell sizes? And
all the same thing.
Okay.
Yeah, because we all fall under the same legislation that way as well. And then I just want to say patient contact studies. So this is a process by which, because we are allowed as an organization to contact individuals, we often have requests for, could we get a cohort of people with the following characteristics, and can we ask them questions or surveys or those kinds of things? So then that's a way to connect with the population. So we just finished a big transition study with the Canadian Partnership Against Cancer, and every province participated, Ontario did, and their goal is to look at psychological, social, and financial burden of patients who were in their survivorship phase. And so we were able to connect with people who had that kind of diagnosis through OCR, had so much time elapsed, didn't have active disease, right? And so we went through and found them as well. So that's sort of, there's a consent process as well. And so we often link back into the registry to do that. So that's my email, and that's the data request email. So that's the one you really need to know, not mine. And that's the link if you're interested in looking at how to access the data. And I think that was the last. Yes, it was.
Do you have a place where one can see, let's say, the data dictionaries or the variable list from your?
So we're actually working on that. Okay. So right now, if you look at data book, your CCO data book, it's a really awful version, but it at least gets you an idea of the data, and it should spell it out by what variable and the definition for some of the databases, not all of the 80 databases.
And then the other piece would be timeline. So from when an event occurs to when it actually appears in these data sets, is there is it always at the end of March 31st, or how do we know?
Well, some of our data is real-time data, and some of it is, so you get it as an annual sort of feed, depending on where it comes from, right? So it really depends. So that's often that intake process is a real discussion with the researcher to say what can be accomplished and when do the data feeds come in, especially if you want to do long-term follow-up, right? Like when do you need to stop your analysis to actually look at the long-term follow-up?
You alluded to sorry.
Okay, so that's about your patient contact. Yeah. And the consent, is that an opt-in or opt-out version?
No, so what we do is we identify individuals as the organization who fulfill your eligibility criteria, then we send them out a letter to say, you may be eligible for a study. Is it okay if we ask you to participate in a research study? So it's a two-step process.
Two-step, but you have to hear back to them. So it's an opt-in. Yes. They have to actually say, okay.
It used to be many years ago, apparently an opt-in. Yes, it was. Before I apparently was arrived. But it's right now, it's you have to actually participate and actively say yes.
Is there any idea what the response rates are?
Yeah, so we're about, it's not optimal, it's about 30%, right? Or under, it depends on the cohort. Women are always good responders, so breast like 30%, prostate 10%, right? So, right, but it's also timing. Do you send letters in the summer? Not really, right? Those kinds of things. So we spend a lot of time talking about when the best way to send letters.
So Nicole, another question. You alluded to the cost piece, obviously, and I know it's hard to give estimates, but if you look at your simple request, you have an estimate, a mean or median estimate of the cost from start to finish for simple requests, at least to give us a sense?
It's a flat administrative fee of $2,100, and then requests are charged at the analytic portion is $75 an hour, or half of that if you're requesting pathology reports. So a simple request is usually done in under 10 hours.
Okay.
So that helps. And then if you're, almost all students here, so I'm scared to say that, but if it's a student request, then we often provide the 20 hours of analytic time?
Yeah, there's a reduced admin fee for student requests, and there's some in-kind hours that we provide.
Yes. But that means it's not Murray asking a question through the student. So we're very cognizant.
You never know.
We're very cognizant of that. No, but I mean, to be fair, we want to build capacity, right? We'd like to see students, and I recognize, with having been a graduate student, I recognize how hard it is to get data and paper data, right? So we're part of this process.
So one more question from online. How about access to data in other provinces?
No.
Yeah.
I'd like to say yes. I can say no very quickly. I mean, we're trying, you know, for example, I worked with Ava Grunfeld on a CIHR grant, Hurricane Impact Grant, and there were 5 provinces, and it took 4 years or 3 years to even just streamline the definitions, right? And they all had to do the analysis themselves. We couldn't share the data, right? So I think I understand that there's a desire to do that. We all would like to do that. We're just not there yet legislatively and privately.
The past data, is there any past data that's available now electronically with the synoptic reporting, say in prostate? Is that at all available?
We still have, well, we have electronic past data as well. We still have drawers full of microfiche, which is fun, depending on which year.
We get the PDF, for example.
Yeah.
We're one of those groups that extracts them. But is there anything with like pulling the synoptic out electronically in a database that we could?
We don't have all synoptic reporting per se. I think there's a move to actually move to that.
Yeah.
Right now,
I know is one of them.
Yeah.
Is anything even recent available? Or?
We can have, I don't think much has changed yet, but like, certainly we can find it free, right? So I'm happy to like answer questions. Please don't hesitate to send me an email. That's my job, is to bridge some of this stuff. So, next question.
Does the ongoing collaboration with ICIS and the data release mechanism here have any implications from your end with CD Link at ICIS's end that you're aware of?
Not that I'm aware.
Okay.
One more question.
Very last question.
Okay, this one is from
Pulling
Anil.
out my student at my thesis.
This one is from Anil from GSK, and asking, to support economic evaluations, do you have cost data and utility data available?
No, so we don't have cost data available. We have some capacity building costs, but we don't have the get cost macro. And some of you may know that through one of my grants, we were working on the chemo costing macro and the radiation costing macro, which are now available theoretically as well. But we don't have that. But the utility data is not yet available. Well, one of the things I would love to do, and this is with my research hat on, not with my CCO hat, but hopefully the two can marry, is when they're collecting the Edmonton Symptom Assessment Scale, which is that ESAS data, which is the patient-reported outcome, and they're at a kiosk. Wouldn't it be nice to do EQ5D at the same time? So we've already done some pilot studies that way. We've done a pilot study at Sunnybrook, and there was just a publication by one of our students out of PMH who had about 2,500 people go through and fill out the EQ5D, but did it at one point in time. So you can see the beauty of doing it longitudinally and all that. And there's a system in place. It's basically set up to do that. We just need to figure out how to potentially, and if there's a desire to do that at an organization level. So that's not my thing. That's my research hat that I would love to do.
With that, thanks so much. Thanks so much, Nicole, for really, really interesting talks. Thanks everyone for coming and a great discussion. Have a wonderful afternoon and weekend. And see you back next week.
I think we can share. I didn't know if we could share, but this is the list of all the databases with the descriptions of the databases. So we're happy to, I don't know, send it to you and then share it. I mean, I just didn't have it ready. So.